Hi, my name is Mike. I'm going to talk to you today about medication-assisted treatment, or MAT. I'll probably refer to it as MAT for the rest of the lecture. MAT is a combination of therapies that includes counseling and behavioral therapies combined with medication, and the primary use is to treat addiction to opiates. It does this by normalizing brain chemistry, also by blocking the euphoric effects of opioids, and by reducing the cravings. The focus of MAT is not on abstinence, but on harm reduction. Now let's take a quick look at the history of MAT. Opiate addiction has been a significant problem throughout the course of history in the United States, and it first became a real recognized problem after the Civil War. This is primarily due to the painful war injuries that were sustained in conflict. Opioid treatment was the standard of care at that time, and it wasn't uncommon for patients to be on large doses of opioids for the rest of their life. As these veterans died off, the majority of the addicts became middle and upper class women who were treated for menstrual discomfort and menopausal symptoms. By the early 1900s, over 300,000 people were addicted. These groups were treated sympathetically by the public, and addiction was just considered an unfortunate medical condition, largely because these groups did not present major social problems. We didn't see bands of roving housewives robbing trains to supply their habits, so it just really wasn't seen as a problem. By the 1920s, though, that changed. There was a lot of illicit opioids, and there was a lot of crime related to the acquisition of those illicit opioids. It became so common that by 1929, Congress was actually forced to act, and they established treatment facilities. These were called narcotic farms, large complexes. There was two of them spread out throughout the United States. Their primary purpose was to treat addiction. They were fairly unsuccessful, and so like anything, the government, instead of looking at why they weren't successful, they thought they would just change the name. So in 1936, they changed the name of the narcotic farms to the U.S. Public Health Service Narcotics Hospitals. These hospitals accepted voluntary patients from across the nation, and many of the patients were also referred by the correctional systems in the area. Because of that, the atmosphere was prison-like, and follow-up studies showed that the narcotic farms, the U.S. Public Health Service narcotics hospitals, were very ineffective, primarily because they relied on abstinence only. And when these patients were released from the facilities, it wasn't uncommon for them to relapse. Fast forward to the 1940s and 60s, that period of time showed a large group of European immigrants moving to the United States. Many of these people were fairly poor, lower socioeconomic strata. So they moved to areas where abuse was common, and because of that, many of them became addicts. This new addict population led to a differing take on addiction. It changed from sympathetic to really non-accepting. Many of the addicts at that time were adolescents. There was a large group of adolescents that were addicted. So New York City in 1952 established Riverside Hospital. It was based on the narcotics farms of the 40s, and it was fairly largely unsuccessful because again it relied on abstinence, not on harm reduction. So when the patients were released from the facility, they often relapsed. During the 1960s and 70s, there was a huge increase in crime and the number of addicts. The Vietnam War, the Vietnam conflict played a large part of that, and a lot of the veterans that came back were addicted to the opiates that they first had contact with over in the Golden Triangle. In 1963, President Kennedy's administration launched research on opioid treatment programs because what had been going on up to that point as far as treatment just wasn't working. So they looked at recommendations from the American Medical Association, and this led to a paradigm shift from abstinence treatment to harm reduction. During this period of time, they they did trials with different long-acting opioids, and they found that methadone was actually a fairly effective agent for both the opioid treatment program and also for pain management. Studies showed that there was improved outcomes with these opioid treatment programs, such as the methadone program, and they use factors such as being able to obtain employment, maintain employment, school attendance, and other factors as guidelines. The follow-up studies did show that there was good compliance and that the participants did eliminate the use of illicit opioids. During the 1980s to the 1990s, there was another dramatic spike in opioid use. And at this point, there was probably 900 to a million addicts that were identified. And at any given time, 200,000 of those were actually actively seeking treatment. In the 1980s, naltrexone, which is an opioid antagonist, was developed, and it did receive FDA approval for alcohol dependence. Because addiction is usually multi-pronged, polysubstance abuse is more common than just single substance abuse. So a lot of the providers that were using naltrexone for their alcohol-dependent patients also were treating opiate-dependent patients. And they did notice that the patients that were addicted to opioids that had gone through detoxification, when combined with counseling and the use of naltrexone, they demonstrated significantly decreased relapse rates. In 1997, the National Institutes of Health recommended the expansion of the methadone treatment program. So there was a large expansion of that program, and methadone clinics began popping up in major cities throughout the United States. In 2002, the FDA approves the medication buprenorphine for use in MAT treatment programs. And this is significant because usually the methadone treatment programs were clinic specific only. Because of the Drug Addiction Treatment Act of 2000, physicians were able to dispense buprenorphine in their clinics. So that was a significant increase. So it actually increased the numbers of patients that were exposed to buprenorphine. And buprenorphine is the opioid ingredient, but typically what we'll talk about now is Suboxone. It's a combination of buprenorphine and naloxone. It comes in a couple different forms. It comes in tablets and films. The tablets really aren't that popular. They take a long time to dissolve inside the mouth, anywhere from 5 to 15 minutes, depending on the patient. They taste horrible, and they leave a film similar to sand. So there's not really a lot of positives on the tablets. The films are much easier to carry and much easier to use, so patients prefer those. There is another form of buprenorphine, which is just buprenorphine only. It's called Subutex, and we use that primarily in pregnancy. It's a Category C medication. And that's because naloxone has never been studied in pregnancy, so they were hesitant to include that in the treatment of pregnant opiate addicts. There are 3 phases of MAT care. The first phase is the induction phase. This is usually the first week of treatment. There will be no opioid use for at least 24 hours, but really 72 hours works the best. And to get them there, we'll help bridge that gap by using withdrawal medications. And the medications in the withdrawal medication packages have changed over the years, but the primary use is to reduce the symptoms so the patient can make it to that 3rd day to make sure that all their mu receptors are clear of opioids. So it's a good induction. After the first week, we bring the patient back for reevaluation, and this begins the second phase, which is the stabilization phase. During this phase, we monitor the effectiveness or the efficacy of the buprenorphine. We fine-tune the dosing. We combine counseling frequently during the first phase, the induction phase, and also the stabilization phase. We try to have our patients speak with our substance abuse counselors at least twice a week at a minimum during the induction phase, and we try to maintain that. It's not always possible, but we try to maintain that throughout the stabilization phase. Once we get everything fine-tuned and we find a good dose for the patient, we'll switch to the third phase, which is maintenance phase, and that's just the long-term consistent use of the medication. Now you're wondering, why doesn't everybody do this? It's really actually, it seems to be a fairly effective program, and patients seem to want to come to areas that provide the MAT treatment. And that's because it's illegal for providers to prescribe opiates to addicts. So under the Controlled Substance Act, we're allowed to get a waiver that prevents our losing our license, and we're still able to maintain our DEA license. But to obtain the waiver, you have to jump through a few hoops like everything else. And there is a government agency that provides training. It's called the Substance Abuse and Mental Health Service Administration, or SAMHSA. They require that you're associated with a recognized treatment facility. They provide training. Usually it's around 24 hours for the initial training. And that gives you a waiver for 1 year. And during that first year, you're allowed to see 30 patients on your panel for MAT patients on your panel. After the first year, you could apply to expand that panel up to 100 patients. And at this point, it's still capped at 100 patients, but the word is that we're probably going to expand that to 250 here in the next year or two. Now, to maintain the compliance with the waiver, you have to keep records and inventories of all controlled substances, and that includes any buprenorphine products. Usually this is handled by in-house staff, but if your facility that you end up working for doesn't provide this, just be aware that you have to keep records and that you will be audited at some point. So that kind of wraps up our background info on this. Now let's answer any questions you might have. Thanks for your time.